the country who do transplants, but there is certainly a shortage for cardiologists. And if you look at the future, which is probably where you should be looking at as young students. One second, I've got some. A lot of work in future will be in terms of organ replacement, be it liver, kidney, heart, bowel. We don't know what else will eventually get replaced. And the other areas where things will change would be artificial organs. They can be from the mechanical side, in terms of developing machines like the total artificial heart or ventricular assist devices, and also biological, where there are two different ways of dealing with that. One is to get decellularized skeletons and then putting in tissue and cells onto it from your own body so that it is not rejected and the body recognizes it as self. And also xenotransplantation. And xenotransplantation certainly will have a future. We'll come to a bit of that as we go by. So anyway, it's going to be a long talk, so I'll just get started. I'm sure you've all heard of Eugene Braunwald. Eugene Braunwald is an editor, or used to be an editor in the Harrison's textbook. And also there is Braunwald's cardiology book called Heart Diseases. The first edition was published when I was a medical student. Now I think it's on to 18th edition or something like that. I'm not very sure which is the correct number. So he said that heart failure is a price we pay for the successful treatment of heart disease, which means that in the past, somebody had a heart attack. So they sometimes didn't reach the hospital. Sometimes they reached the hospital, didn't get much of effective treatment, and they died. Now, if you reach the hospital with a heart attack, you're likely to get very effective treatment in terms of either thrombolysis or primary angioplasties, which help to save some muscle. But the disease doesn't go away, and you don't die with that disease at that time. But the heart muscle goes on getting damaged over a period of time, and then they all end up having heart failure 10, 20, 30 years after the primary event. So it is a price that we have paid for keeping people alive in the primary event. So as I said before, as you all become senior consultants, heart failure and treatment for these conditions and other organs also would form a major chunk of your work. Now, when you look at treating a failing heart, there are certain different ways of doing that. One is medical treatment, which is what we call as the guideline-directed medical therapy, with tablets which include ACE inhibitors or ARBs and diuretics and beta blockers and such. And in an acute situation, we use inotropes like adrenaline or dobutamine or milrinone in order to get you out of the acute heart failure. And sometimes it is reversed depending on the condition. Sometimes it leads to a chronic state which requires to be addressed at a different level. There are devices like IABP which can support for a little while, maybe for a few days, and provides small amount of support, but IABP is very commonly used and available everywhere. And there are some surgical procedures which are not for advanced heart failure, like surgical ventricular restoration, which is done to deal with the ventricular aneurysms, and sometimes repairing of mitral valve or replacing mitral valve to deal with the mitral regurgitation. Today, there is also a percutaneous option for that called MitraClip, where that can be deployed through a catheter, and the mitral valve can be repaired with that. In terms of advanced therapy, what I want to talk to you about is mostly about heart transplantation and a little bit about biventricular assist or total artificial heart, and some more about LVAD. And ECMO is certainly a short-term therapy. So we use ECMO when someone's come in and we don't really know what the whole situation is. So you put on ECMO, you can keep them alive, then you can do further assessment and then decide if you want to put them on another device which lasts. ECMO typically you make or break within a period of 1 week to 10 days. Within that, either they recover or they die, or you have to shift to another more durable temporary, or what is called as durable device. Okay, or then or look at doing a transplant. If you're on ECMO, you get priority in terms of allocation of a heart, and you can do that more quickly. So in terms of treatment for end stage heart disease, cardiac transplantation is the most definitive treatment. There are other options like LVAD or total artificial heart. They are all not as good as transplant as of today. It might change in the future, but today heart transplant is still the gold standard for treating end stage heart disease. Now, just to put things in perspective, advanced heart failure is the principal cause of death in about 40,000 patients in the US, and it contributes to another 250,000 deaths. We don't have correct statistics available for us. So if you look at the population, you can do the math. And there is a lot of expense involved in treating heart failure. And worldwide expense is estimated to be $108 billion. And most of it is direct cost, not in terms of loss of employment or loss of productivity, etc. These are famous moments from history. The first heart transplant really changed the whole field of cardiac surgery. The transplant was reported in lay press, and subsequently it came through with a lot of criticism also. But when you look at the scientific part of the transplant, you have these two gentlemen, Norman Shumway and Richard Lower, who actually described the original procedure for the transplant. Christian Barnard did the first transplant. He made a slight modification to the procedure these gentlemen had made. And what we use today is a different procedure, which I'll describe later, which was described by Professor Yakub and Reitz. And Richard Dreyfuss, the gentleman here, he came up with another procedure called total heart transplant, which did not really become very popular. I was fortunate to have a discussion with him, and he explained to me why he came up with that concept and all of that. But unfortunately, both Professor Yakub and Dreyfuss are no longer doing transplants. When you look at the history from a scientific perspective, apart from Shumway and the others whom I mentioned, there are a few others which need to be mentioned. Alexis Carrel received the Nobel Prize in 1905. In 1912. He is the one who made vascular anastomosis possible. The techniques we use to connect two blood vessels today is the same thing which he described at that time. So you can imagine it is something which is really withstood the test of time. And I spoke about Shumway and Lower. Now, another person is Peter Medawer. He also received a Nobel Prize in his work in immunology. He is the one who laid the foundation for understanding rejection and to show that it is a immune-based phenomena. The people who really worked towards the first transplant, which has been chronicled well in this book called Every Second Counts by McRae, is Adrian Kantrowitz, Shumway, and Christian Barnard. So it's a very interesting book if you're interested in the history of these things. So Kantrowitz did the first pediatric heart transplant. That was from the donor was an anencephalic child. That led to a lot of controversies and all of that. So he stopped doing transplants with that. The people whom we really owe the good success to today's transplant are Philip Caves and Margaret Billingham. Caves designed a bioptome where you could put that bioptome into the heart through the femoral vein or jugular vein and take a bit of endomyocardium for biopsy. And Margaret Billingham came up with the histological gradation of rejection. See, what happens is if you have rejection and you wait for clinical manifestation in terms of left ventricular dysfunction, you've already missed the boat. So what is done today is to do surveillance biopsies and pick up rejection before it becomes clinically apparent. And of course, there is in any field, Denton Cooley has done something or the other, and he did the first combined heart and lung transplant. In India, it is interesting, PK Sen, he did the first transplant in India 1 year after Christian Barnard. This is something which many of us are not aware of because the patient did not really survive. The first transplant, which was done after the Transplant of Human Organ Act was passed, was by Dr. Venugopal in All India Institute, and the first pediatric transplant was done by Dr. Cherian in Chennai. Now, when you look at patients who are listed for transplant, either they have severe angina or severe heart failure, or sometimes life-threatening arrhythmias. The heart function may be all right, but they may be at risk of death from arrhythmia. So these are the groups. And also, like, we have children with congenital anomalies, which sometimes functionally they may be reasonable, but we are not able to correct it. Therefore, we do either heart transplant, or if the pulmonary arteries and veins are not well developed, then you do a heart and lung transplant. So when you look at them, most of them they've got a ejection. I'm saying ejection fraction because that's one of the most widely measured metric, even though that is not the gold standard in terms of understanding heart function. But let's look at ejection fraction. Most of the people whom you take for transplant have a low ejection fraction, generally below 20% or so. Now, you have to look at all these people after giving them maximal medical therapy. It is not like somebody comes to you for a heart failure and you just start talking about transplant right away. Many people improve very well with medical therapy. Now, if you look at the results of what is called as a rematch trial, 1 year survival in medical therapy arm was very low, it is 25%, and 2 year survival was 8%. So this was compared with the use of a left ventricular assist device, and they had a much better survival, to the point that the study was stopped in between because the results were so obvious. And anyway, we'll come to that later. So this was done at a different time period. We still quote these studies, but medical treatment and LVADs also have improved a lot since that time. So we shouldn't be looking at 25% 1 year and 8% 2 year survival today with medical treatment. So when you're looking at a patient who's come with heart failure, first you must address all the reversible components and causes of heart failure. For example, one day I was sent a patient who was for a left ventricular assist device. When we went through the history, we understood that he was taking a medication which was causing his heart failure. So we stopped the medication, waited for 3 months, his heart became normal. So it is important that you take a proper history and look for any particular cause that may be there which can be reversed. So the next thing is to evaluate the severity of heart failure and what their functional capacity is. As I said before, we don't go by the EF as a metric all the time. There are other things to look at, and you should look at that again. We'll come to some of the evaluating parameters later. So we should also look at who are the ones who are likely to deteriorate quickly and have sudden death. Sudden death is usually from severe heart failure or arrhythmias. So many of them might benefit from using a AICD, which will prevent life-threatening arrhythmias. Then once you've done all of this, you see if they're a candidate for cardiac resynchronization therapy. And finally, we have a multidisciplinary assessment and then decide if they are candidates for transplant. And then while you're waiting, you have to continue with the heart failure management and reevaluate them from time to time. So in general, you have to look at the presence of an indication and absence of contraindications, and then they become candidates. So that is, fairly simple. The criteria for listing has been published by International Society for Heart and Lung Transplant in 2006, and it was revised again in 2010. If you look at the authors list, you find quite a few Indian names around. So, over the years, I'm thinking some of you might figure in these documents as we speak. So from the listing criteria, you have basically you're trying to assess for presence of indications and absence of contraindications, right? So cardiopulmonary exercise testing is a test that we do, which tells you how much oxygen is being consumed at the peak of exercise. So you have to get to a point where you get to anaerobic metabolism, which can be measured on the device. And with that, we have guidelines at what point we should look at listing them for transplant. And there are other scores which are available, which helps you to predict the survival over 1 year. All patients will get a right heart catheterization. I'll get into details of that. And then you have to look at other comorbidities, other organ dysfunctions. Diabetes is not a contraindication in the absence of severe end organ disease. Tobacco and substance abuse would form contraindication for transplant. So as I told you about CPET, so these are the levels which are recommended for CPET. I don't know if you need to know all these in detail, but anyway, I know some of you will be recording or taking pictures, so I just put these up for that. Right heart catheterization forms one of the most important tests which we do in terms of doing a heart transplant. What we are trying to do is to assess what is the pulmonary artery pressure, resistance, and what we want to know is when you put in a new heart, which is not used to having a high pulmonary vascular resistance, into the patient whose PVR may be high because of left heart disease, will that heart function or not? If the normal heart, which you get from a recipient, is faced with a sudden increase in the pulmonary vascular resistance, it will fail. The normal hearts are not capable of generating more than 50 millimeters of mercury pressure when it is faced with a severe afterload, and it tends to fail. But if a heart is used to having a high PVR, and if it happens over a period of time, it adapts and becomes hypertrophied and behaves like an LV and can generate pressures which are equal to the LV. But in an acute situation, the RV tends to fail and it just cannot cope with the high PVR. You remember from physiology that right ventricle is a volume pump as opposed to left ventricle, which is a pressure pump. So the right ventricle will not be able to cope with the pressure head. So right heart catheterization is intended to understand that. Frailty is something which we all use very loosely as a term, but it is defined and there are tests to tell you who's frail and who's not. So these are a few things which have been described. There's a score called the Fried's Frailty Index, which takes into account all these things: loss of weight, fatigue, slow walking speed, all of that. And if a person is frail, their outcomes are not as good as a non-frail person. But as of now, we do not have a recommendation from ISHLT not to do transplants on frail people, or at what level of frailty you must not do. We have known that there are patients who got reversible frailty, like because of the heart failure, they're not eating well and they become frail. In those people, if you put a left ventricular assist device or a transplant, if they survive the transplant, their frailty tends to go away. So the other thing is, if you find that somebody has got reversible or treatable conditions, you can bridge them to transplant using a mechanical device like an LVAD until that is reversed. So if somebody's got cancer and we don't know if he's going to survive cancer, we do not want to waste a donor heart on someone who's going to die with cancer. So you could use use a left ventricular assist device and get some time and see they're cured of cancer, then do the transplant. Same thing with obesity. The cutoff is about 35 for BMI. Now, what happens is, once you put the obesity, put a left ventricular device as bridge to transplant for obesity, people tend to become more hungry and they eat more. And instead of it becoming a bridge to transplant, it just becomes a bridge to the fridge. They can walk easier, they go and eat more, and they become even more obese in terms of reality. I've just put up the exclusion criteria just to show that things have changed over the years. We've increased the age at which you use. Renal insufficiencies become even more tolerable. And things like amyloidosis, which used to be contraindication before, have now become indications, and we are happier to do these operations now. Because with increasing experience, all these fields evolve, and what you thought as inoperable becomes operable after some time. Now, we must remember the success of a transplant begins with the donor organ. So assessing, protecting, preserving, transporting, and taking care of a donor organ is of utmost importance. Dr. Wahlberg has made a lot of quotable quotes, and one of them is, "You cannot make chicken out of a fried egg." So if you do not look after the donor organ well, your transplant is not going to work. The first thing is about assessment of donor. So the assessment are two things. One is to see if the donor is suitable for donating the heart or other organs for that matter. And the second thing is to assess if that donor organ is suitable for your patient whom you intend to do the transplant for. So you need to do a size match. With sex matching is not so important as long as the size is reasonable. If you put a small female heart into a large male, the likelihood is it will not work. So it would be like putting a Maruti engine into a lorry and expecting it to pull the load. It probably won't. It's just to do with it's not to do with the gender as such. It is to do with the muscle mass and the ability to function adequately for a larger body mass. So there are calculations which we can do in order to understand if there is a gender and size mismatch. There are also cardiac contraindications and other contraindications. So we look at all these in general. Most of the times, one of us will go to the donor hospital and make an assessment personally. And clearly, the best assessment is by a surgeon who's an experienced transplant surgeon. We always think that the heart will talk to us. Once you see the heart, you have a much better idea than all the other tests put together. Clearly, many of these contraindications make common sense. Cardiac contraindications, where there's a problem with the heart itself. Then if there is serology which is positive or malignancies. Having said that, I have taken hearts which have had cardiac arrest or arrhythmias. Depends on how desperate you are. You've got a patient who's about to die. So sometimes you may cut some corners and take a heart that is not as, which you wouldn't have taken for a person who's walking around on the street. There is the whole concept of preserving a donor heart. So at the time of retrieval, we protect and preserve the integrity of the heart at a microvascular and cellular level, so that the functional integrity is preserved throughout the transplant process, which is sort of very, very abnormal for any organ. Hypothermia forms the key to reducing the metabolic demands, and we use that by cooling the heart and packing it in ice during transport, and until you're ready to do the implant, you keep it in an ice box. There are various solutions that are used in order to protect. They've got advantages, disadvantages. So what we use generally is what is called custodial. That is the solution we use. We give 2 liters of custodial, and that is what we use as the flush. A few things about donor heart procurement. So usually it's a multi-organ retrieval. So you have an incision which goes from the suprasternal notch to the pubis, and one team will be working in the abdomen, one team will be working in the chest, sometimes more than one team, and we take turns. So sometimes people will be harvesting the limbs also, so they also need space. So we have a lot of people who are fighting for space to stand there. So generally, you open the pericardium, inspect the heart, and make sure that it is something which you want to take. You palpate the coronaries if you've not had a coronary angiogram before. After you palpate the coronaries, and if you are satisfied with the whole thing, then you start, when you give the cross, we put the cross clamp, give the protective solution, and then cut the heart out by its attachments. The inferior vena cava, the pulmonary veins, pulmonary arteries, aorta, superior vena cava, all have to be cut. Then it is packed into this same solution and triple bagged in ice. So as we are working with the donor heart, somebody will be opening up the recipient, and one would start by putting them on cardiopulmonary bypass. And once you get a go ahead from the donor surgeon, they would go on and remove the recipient's heart. So there are basically 2 techniques in doing the anastomosis. One is called the biatrial technique, where the anastomosis is done to the 2 atria, to the left atrium and the right atrium. The other one is the bicaval technique, where the left-sided anastomosis is done to the left atrium, but the right-sided anastomosis would be to the superior vena cava and the inferior vena cava separately. In general, people do the bicaval technique because of some advantages it provides, like the development of tricuspid regurgitation is less in this technique. So it is more popular today. Some of us older surgeons would have been trained in the first technique, but generally we all do the bicaval technique now, unless there is some specific reason to do the other one. I think we are already on to about half an hour. So if I play the videos, we may just run over time. So I'll just skip the videos. It's just illustration of the techniques which I told you. But if you do want to see the videos, and if there is time later on, we'll look at that later. So some amount of preparation is required for the donor heart. In order to prepare for the anastomosis, we cut between the pulmonary veins like a cross, and make the left atrium into one chamber. And you may have to excise a little bit of the edges to suit it. And there is usually a size mismatch, which can be adjusted by tailoring the organs. Okay, and there are a few anastomosis which is done. For the inflow anastomosis, as I mentioned before, in the bicaval technique, you would anastomose the left atrium, the far wall, and then this portion will go there. So the left atrium is anastomosed to the recipient's left atrium, and the superior vena cava and inferior vena cava are anastomosed respectively to the superior vena cava and inferior vena cava of the donor. In the biatrial technique, it is slightly different. The LA anastomosis is similar, but this portion goes on to the interatrial septum there. And the opened right atrium is anastomosed to the right atrial stump here. So this is the modification which was done by Christian Bernard. The original technique Shumway developed made an incision from the inferior vena cava right up to the superior vena cava. The problem with that is the SA node is situated there. You cannot really see it. And the chances of injuring the SA node is higher if you make the incision like this. There was just once where I had to do the incision like this because it was injured by the lung harvesting team in a similar manner. So I just decided to use it this way. Okay, we've in the, as I said, with the right side, if you're doing a bicable, you would anastomose these IVC to IVC and SVC to SVC. And in biatrial, as I said, to the opened up RA, it is anastomosed to the RA. Okay, so then we have the aorta and pulmonary artery. So at the completion of a bicaval anastomosis, it looks something like this. You have a PA anastomosis, aorta anastomosis, SVC, and IVC. And if it is biatrial, the right atrial anastomosis will be there. Otherwise, it is quite similar. Okay, so then when you complete all the anastomosis, you have to remove all the air from the heart, because if you do not, then some of the air will get into the right coronary artery and then the right ventricle will not work, and you may have to use some form of support for that. Often pacing is required due to sinus node dysfunction, and you remember the heart is denervated, so all the drugs may work very differently. Sometimes you may have to use IABP or ECMO post-transplant. There are a lot of problems that can happen, rejection and related phenomena. And what we are really worried about at that point is what is called as the primary graft dysfunction or primary graft failure, where the transplanted heart just doesn't work. But if you support them mechanically for a few days, most of the times the heart picks up its function, and you can see the patient recover in a week's time. Of all the primary graft failures which I have seen, none of them have died from that cause at that time. You support them early. Don't wait till you flog them with a lot of inotropes and all that, and then the heart tends to recover. Hyperacute rejection is not something which we see these days, because we do a cross match and we carefully look at the HLA, anti-HLA antibodies which are present in the recipient. So in terms of immunosuppression, we use induction therapy with either ATG or basiliximab, and there is a triple drug maintenance therapy which includes one calcineurin inhibitor, one anti-metabolite, and steroids. Okay, so the complications include rejections of one form or the other, and late complication is it's a form of chronic rejection, which is the vasculopathy, which affects the coronary arteries. Now, this is a situation which not many people have seen, even cardiac surgeons. As you can see, there is no lungs in the thorax. There's no heart in the pericardium. So you can see the cut into the aorta, pulmonary artery. The IVC will be here, SVC will be somewhere here. So this is a patient. He's on cardiopulmonary bypass. You can see the cannula there, aortic and the two venous cannula. So he doesn't have a heart or lung in place, but he's kept alive with the cardiopulmonary bypass. And then we bring in a set of heart and lungs together. This is an en-bloc heart-lung transplant. You see this portion of the lung is injured, which was subsequently removed. So you put the whole block inside, And you can see this is the tracheal anastomosis here. You stitch the donor trachea to the recipient trachea, and then you have to do the aorta, inferior vena cava, and superior vena cava. So a patient who came in and was on ECMO, ventilator, and a ton of other medications get this sort of a transplant. And this is a picture I took about 2 days ago. He's still in the ICU, recovering, and this is what's the outcome of someone who can barely breathe or walk before that. So this is just to show the number of transplants we've been doing. As you can see, COVID really took a toll on this whole program, and we've not been doing many transplants since the COVID, and it's just sort of beginning to pick up now. So I'll just run through, I think I still have about 20 minutes, so I'll run through mechanical circulatory support as well. This is the results from the rematch trial, which I spoke to you before. The medical therapy arm showed a very rapid decline, and the patients who received or randomized to LV assist device tended to live much longer than the medical arm. So you can see the numbers here. This trial was stopped at some point because the superiority of an LV assist device was proven. Now, they had used the HeartMate 1 device. This is a very primitive device, which is no longer available in the market. It had valves inside. It was a huge pump. You required something like 2 meters square of body surface area in order to fit this in. But today, in relation, the pumps are much smaller. Now, this is the latest pump we have. So look at the size difference. In spite of that, this device had scored so much better than medical treatment. This is the only HeartMate 1 device which I had seen at explant. You can see this, there is a lot of soot inside. So that was the way this device was. It wouldn't run for more than 1 year or 18 months. But now, if you look at the devices, they are nearly equal to the transplant results in the short term. I'm not, I'm underlying the fact in the short term, as in 1 year or up to 2 years. Transplant certainly scores above these devices when you're looking at the results beyond 2 years. Maybe in the next 5 years or so, you might have devices which are much better in its engineering, and you may find that they're equal to transplant. We all wait for that day. Now, when you look at mechanical circulatory support, there are different indications in which we categorize them. One is bridge to decision. Suppose somebody comes in severe cardiogenic shock. We put in a temporary device without thinking too much. You keep them alive, and then you make all the assessments. You didn't have enough time to even decide what the problem is. So we just quickly usually use an ECMO, put in the device, then you try and understand what the problem is. And then you may decide to, if you think that the patient will recover, then you keep them on that device until they recover, which you probably cannot keep more than a week or 10 days. Then it becomes what is called a bridge to bridge. Then you use another device in order to get them to either transplantation or as a bridge to recovery. And if you think that they're not transplantable, we use a durable left ventricular assist device as a destination therapy. There are a whole lot of temporary devices. These are meant for short-term use. So our go-to device is the ECMO, or what is called the CentriMag. CentriMag is generally used as a biventricular assist. In an ECMO, in addition to supporting both the ventricles, it can also use an oxygenator and support the lungs. The CentriMag can be used in various configurations. You can use it as an ECMO. You can use it as a left ventricular assist device. You can use it as a right ventricular assist device, or as a biventricular assist device. You have 2 consoles and 2 pumps. So depending on how you configure it and where you cannulate, you can use it in various ways. Some of these, this is a percutaneous device called Impella, which is available in the country. The disposables in this cost about 25 lakhs. So, it is not very popular because of the price. This is one type of a total artificial heart, which is again used as a bridge to transplant. It is called CARMET. And this is the only device which is available for all sizes, right from neonate all the way. It's made by a company called Berlin Heart. From a neonate all the way to adults, you can use these devices made by Berlin Heart. These are temporary devices. It tends to clot inside this, so you have to make multiple replacement of these at times. And in India, a set of this will cost about 1 crore. So therefore, it is very difficult to get to use one of those. This is the total artificial heart, which is most frequently used. It is from a company called Syncardia. This is available in the country, but nobody has made an implant so far, primarily because it costs 2 crores or so. So if you have this, you would tend to remove the ventricles and stitch this to the atria. You have two types of drivers. One is something which you can carry in a backpack. The other type of driver is much larger. You have to roll it around as a big console. So depending on what the problem is, you have to choose the right device. So this is a slide from Syncardia. So if you have a patient with arrhythmias, and when you use a left ventricular assist device, by definition, it is supporting only the left ventricle. That means the right ventricle should work adequately in order to provide the blood across the lung into the left atrium. Only then the LVAD can work. But if there is a right ventricular dysfunction, you may want to use a biventricular assist or use a total artificial heart. So in a total artificial heart, you don't have to worry about the right ventricle. And there are some advantage of both these. These are the more durable devices. We started our journey with this device called VentrAssist. We did a lot of implants of those, then the company wound up. And many of our patients outlived the company. They continued to live many years after the company shut down. And one patient actually underwent transplant 10 years after putting in this device. Today, this is our go-to device called HeartMate 2. The other one is HeartMate 3. This is called Heartware. It's got a different technology, but they've withdrawn that from the market. This was available in the country before. One of the advantages of this is that it can be monitored remotely on the internet. It has got connectivity, and it's like a modern gadget, but nobody is using it in the country now. This again is called EVA Heart. Is a new kid in the block. It's become available in the last year, but no implants have happened so far. It has got some advantage over the other devices that it can tolerate a little more of right ventricular dysfunction. This device is called Jarvik. One of the big advantages of that, the driveline for the Jarvik comes out from the mastoid process. So the driveline infection is very, very minimal in this device. Most devices work in a certain way. You have an inflow cannula where the blood from the ventricle would come inside. It will go through some kind of a stator which streamlines the flow. There is an impeller which rotates with the use of electromagnetic force, and it is pumped across, and these are held on bearings. Depending on the design, you have either bearing with bearings or sometimes without bearings, particularly in the centrifugal pumps, and it is pumped through an outflow graft into the aorta. And there is a drive line that comes out of the skin to which you connect a controller and the batteries. So when you look at LVAD, the most important thing, like many other surgeries, it is in selecting the appropriate patients. Suppose you select a patient whose right ventricle is not working well, you're not going to have success with your LVAD. Or if there are bleeding diatheses, they just bleed so much that you'll never get through. So the challenge is to find someone who is sick enough or ill enough to require this therapy, but not too well that it is not going to give him any additional benefit. So you have to choose a patient at the right time, and make sure that they're not so far progressed. Like if somebody comes in cardiogenic shock, we do not put them on LVAD. You would use a temporary device and see if they recover. If they recover, then we plan on a durable LVAD. So in other words, a durable LVAD is never an emergency procedure. So these are situations that are similar to heart transplant, but there may be some contraindication to heart transplant. So that is when you would prefer to use an LVAD. Not sure why all these lines are coming up now. Anyway, when you look at the preoperative assessment, assessing the right ventricle is probably the most important thing. So we spend time to do all the calculations to understand the right ventricle. Then you make a plan about what else needs to be done. If there's a valve to be addressed, if there are any intracardiac shunts to be addressed, if there is coronary artery bypass to be done, and we look at all the other systems very carefully in order to assess what the outcome would be. Now, normally I spend about 2-3 weeks preparing a patient towards LVAD. You would have to remove all the excess fluid and optimize the cardiac output, so they are in the best situation before you take them for LVAD. You dry them up so much that it is said that there should be a fire hazard for spontaneous ignition. So it should be like dry leaf, they should be so dry. You prepare them with inotropes, improve the cardiac output, correct the anemia, rehabilitate them as much as possible. You need them to be able to breathe well, walk around a bit, take care of nutrition. Some of these trace elements like copper seems to be very important in the outcomes of LVAD. I really do not know why. So we just make sure all these are corrected. We have a multidisciplinary team to make sure that all these things are looked into. A little bit about the procedure. We mark out the skin, what we need to do. And for a device like HeartMate 2, which is very bulky, you need to make a pump pocket. And then we you see the device is there, and this is the drive line. And the drive line has to be brought out through the skin near the abdomen. So we use this sort of a tunneler to bring it down and punch a hole in the skin with this skin punch, which comes with the kit. You find out the apex, and you can corroborate that with transesophageal echocardiography, and you make a hole in the apex. With there is a knife which comes. It's a circular knife, so we use that knife to punch a hole into the apex. And almost all the devices will require you to punch a hole in the apex one way or the other. And in this HeartMate 2, you need to take the sutures and fix this cuff there. And through the cuff, we pass the inflow cannula and tie it there. We use a tie that comes with it, and also the cable ties which you use to tie your garbage bags. Similar ties are used in putting it in place. And then the outflow graft is anastomosed to the aorta. You could do this step as a first step also if you like, because all these connections can be undone. So if there is a problem with the pump, you can just unscrew it here and unscrew it here and replace the pump at a future date if there is a pump thrombosis or something by going subcostally. You don't have to really reopen the sternal incision. So this is what it looks like. You have to remove all the air from the heart and from the device. So you put in a needle there and you let the pump run and remove all the air. So that's the echocardiography, which shows. Okay, so if you see on the echo, you should see good streamline flow from the mitral valve into the device. So the device should be placed in a manner, the inflow cannula should not be impinging onto the septum or to the free wall. It should face the mitral valve. So that is good placement. You may have to address a lot of other things which are there in the heart. If there is aortic regurgitation, you have to either replace the valve or you can shut the valve off completely, because the blood will bypass the valve from the left ventricle. It goes through the device into the aorta. So you can close the valve. If you have aortic regurgitation, the blood will go from the LV through the device into the aorta, and through the aortic regurgitation come back into the LV, and the blood will just move in circle in the heart and not perfuse the body. So it is very important to address aortic regurgitation. With many of the other things, it is, plus minus. Mitral regurgitation may be left alone. Some people believe in addressing tricuspid regurgitation, some don't. If there is a intracardiac shunt, including a PFO, it needs to be closed, because once you put a powered pump on the left side, you will get a severe right to left shunt if there is an intracardiac shunt of any kind. So you must remember, once you've put in a device, it's like this. You have the left heart, which is a machine, right heart, which is all flesh. So all the rest of your therapy in terms of drugs and anything else is directed at the right heart. So we remove all the air so that the right coronary artery doesn't get air inside and stop the circulation there. Optimize the preload and afterload, and make sure there are no kinks in it. And if you have right ventricular failure and a short trial of inotropes don't work, you must use a temporary mechanical circulatory support. So sometimes we use a Centrimag pump, like shown here, for which we generally stitch a little graft. So you stitch a graft to the pulmonary artery, bring it out through the subcostal area, use a femoral venous cannula, and use a right ventricular assist device temporarily. Once the right ventricle recovers, you can see here the pulmonary artery is bulging. That means our right ventricle is not working. So the whole thing looks bulged. Once the RV recovers, you can pull this a little bit and cut it and remove the femoral cannula without having to reopen the chest. There are lots of problems with left ventricular assist devices. Something like, bleeding is a big problem. RV dysfunction I spoke about. You see, it was a frail patient. His wound broke down, is just not healing. There is a collection of blood inside. So it is not always pretty. And there are a lot of late complications. The left ventricular assist devices provide continuous flow, and the body is not designed for continuous flow. You do tend to develop some, 1 Willebrand factor deficiency leading to bleeding, and angiodysplasias with neovascularization. So that can lead to nasal bleeds, GI bleeds, intracranial hemorrhage. Sometimes thrombus will cause strokes, bleed will cause strokes. So intracranial hemorrhage or thrombosis. It is a fine balance between, preventing pump thrombosis with lifelong anticoagulation and preventing bleeding from various places where the pump itself will predispose it to. There are troubles with the driveline in terms of infection and fracture of the driveline, etc. Pumps can get thrombosed, and a lot of patients will develop late aortic incompetence. At some point, you may need to address it if they develop it over time. That is why I was saying these are all nice for 1 or 2 years. But as time goes by, the number of problems also increase. So as a bridge to transplant, to keep you alive till you get a heart for transplant, these are great devices. But as destination therapy, it is not as good as transplant. So these are some patients who had durable assist devices. This gentleman is on a biventricular assist device, doing exercise, hoping to get a transplant. So transplant is certainly the gold standard, but there is a severe shortage of organs in all parts of the world, and therefore we have to use all these devices in order to bridge them towards transplant or use as a substitute. Shumway had said that xenotransplantation is the future of transplantation, and it will always remain in the future of transplantation. he did not think that it is going to become clinically feasible. As of now, also many years after Shamve, clinically it is not feasible, but I am hoping that I will see xenotransplantation happening during my practice lifetime. Even if it's after my retirement, it's okay. I'd just like to see it happen. So the LVAD is a good substitute for some patients who are unsuitable for heart transplant. And you must remember that the transplant hearts are very precious resources. You can't take them off a shelf. It has to be donated by a person who's brain dead. So until there is a good substitute, otherwise LVAD is the only thing we have. If you look at the number of people who are bridged to transplant with an LVAD has been steadily increasing in the US, or like this is an international registry, but good part of the contribution comes from US and Europe. So nearly half of the patients who undergo transplant in these countries today are with a LVAD in place. So you are going to, as I said, this is continuous flow. So you will not be able to feel a pulse in these people. You will have to measure blood pressure as the mean pressure using a Doppler, because you cannot feel a pulse. You cannot hear Korotkov sounds at all. So these are something which you are going to have to get used to. In the initial times when I send a patient for consultation to somebody else, I would go with them so that they don't start doing CPR, because you don't see a pulse. And if you do a CPR in someone who's got an LVAD, the LVAD will just get torn off the heart. So you cannot even do CPR on them. So as we progress in technology, you might see smaller pumps and smart pumps. Today is the day for everything being called smart something or smart other things. So as of now, we have only dumb pumps, which you can set a speed and it runs at that speed. It is not responsive to the body's needs like the heart is. So maybe in future, you might have some feedback mechanisms which make the pump work differently for different situations. So just want to tell you one other thing. There are a whole bunch of infective complications that come out of LVADs. Driveline infection is one of the commoner problems. You see this whole place is infected. So sometimes you can treat it by local debridement, etc. Sometimes you need to do the pump replacement. You see this gentleman, Ivan Netuka, did what is called the first driveline-less or percutaneous charging system in the Czech Republic. He had come and worked here for some time in Chennai, so we are familiar with him. So this device, they have an implantable battery that goes inside the chest, and there's a coil inside the chest, which is an induction coil. When you keep where this vest there, this will charge the battery through this coil, and it can run for a few hours, and a watch on the wrist will work as a controller. So this is a very fancy system. This was used in 2 patients as a bridge to transplant, mostly as a proof of concept. They used a Jarvik so that there is a drive line as a standby, which was fixed onto the mastoid. And after this 2 patients, they have not done anymore, but there is a lot of work going on in Ivan Netuka's place, and many companies are working with him in order to make their device also free of the drive line. So thank you very much. I think I took a little bit extra time. Sorry about that.
Okay, if you have any questions, you can put it down in the chat box now. We have a question. It says,
so if you have questions.
Okay, someone has a question. It says, when it's a pediatric patient and there's a need for transplant, is LVAD an appropriate choice? So is LVAD an appropriate choice in a pediatric patient?
I'm sorry, I didn't hear the first part of the question because this was, I muted it at some point.
Yeah, sorry. The question says, if given a situation where a pediatric patient is in need of a transplant, is LVAD an appropriate choice?
So at the moment, we do not have a lot of choices for durable LVADs for children, particularly smaller children. For the hardware was a good choice, but hardware got withdrawn from the market. So we do not have that device available anymore. We have temporary devices like I showed for the Berlin heart. Berlin heart can be used in any age from neonates up onto adults. They are, it's not the same device. They come in various sizes for each body size. And they are devices which are kept outside the body. And these are not things which you can discharge a patient with. So we don't have a good pediatric device as of now. There is one from the Jarvik. The Jarvik device is also not good for infants, but in children it can be used. They are much smaller devices, but we don't have it approved in the country. So we cannot use a pediatric LVAD as such. But pediatric transplants we do. If you look at pediatric transplants, broadly there are two types. One is cardiomyopathy and diseases like that, where the heart itself is morphologically normal. Then you have the set which have got congenitally malformed hearts. Sometimes single ventricle, sometimes they are situs inversus. So the donor heart which we get is morphologically normal, and therefore it requires you to do a lot of tailoring to fit a normal heart into an abnormal anatomy. But it can be done. All the anomalies which are there in a child can be dealt with by either heart transplant or heart-lung transplant by tailoring these structures. All the techniques are described, so we are able to do all of that. So to answer the question in short, there are no reliable pediatric LVADs available. So transplant is now the only option. But we do have temporary LVADs, which we can use as bridge to transplant if a child crashes.
Okay. Someone else asks, what is the scope of stem cell growth heart and also 3D printed hearts?
I hope to see all this happen sometime in my life, but at the moment they're not feasible. We have done all these stem cell injections and all that. They don't really work.
Okay.
And 3D printing the heart is nice for demonstrations and making talks, but not to make it work. I don't know if it will work in future, but as of now, they're nowhere near a working model. And there is also, there are stem cells that you recover out of muscles and you make them differentiate into cardiomyocytes. All that is done. It is even done in Bangalore. You can make them form a syncytium and you can see them contract. But developing an organ out of it is much farther away. But someday it may be possible. If you look at the ventricular muscle, it is basically one big sheet of muscle which is wrapped. So what you need is to develop a big block of cells which form muscle, and then you can construct a ventricle out of it. But not something which I might see myself implanting one day. Maybe you all will.
Okay, there's another question. He says, how can we resuscitate a patient on LVAD?
Yeah, that's really, really difficult. If it's in the immediate post-operative period, what is best is to reopen the wound and do internal massage. So we will be able to do that in the immediate post-op period. But if it is somebody who's 1 year out into the disease, usually at that point, the reason why you would need resuscitation would be because of ventricular fibrillation. Ventricular fibrillation in the immediate post-op period is very different from late post-op. If a patient has ventricular fibrillation in the late post-operative period with an LVAD in place, usually they do not drop dead. They just feel unwell and they reach the hospital with the ventricular fibrillation going on. And ECG is going to tell you, they just say that I'm not feeling well, because of lower cardiac output. The LVAD will provide some amount of flow, but not optimal. and then you can shock them back into rhythm. So otherwise you have to use a ECMO or some device like that. But massage would be very dangerous because you dislodge the device from the LV, and that would be the end of it.
Okay. Someone asked if you could explain a bit about the piggyback heart transplant.
Yeah, see, these are done in specific instances where suppose and I spoke about pulmonary vascular resistance earlier. So if you have a patient who's got a high pulmonary vascular resistance, if you put in a normal heart, it's not going to work. So one option is to use an LVAD. Now the piggyback heart can be used like an LVAD in the way you connect it. So the native heart remains, and this will be an additional one. So there are a couple of cases which were done in Coimbatore, but largely it's not popular worldwide. It was done at one stage, and there were talks of a revival in the recent past, but really didn't catch on.
Someone asks if denervation causes any problems in pediatric transplant post-surgery.
See, all transplanted organs are denervated, heart, lungs, all of them. So if you denervate a heart, there are problems with the absence of sympathetic and parasympathetic supply. So you may find them tachycardic or bradycardic, usually bradycardic. And many drugs like atropine, you give them atropine, nothing happens because you require, the atropine works through the parasympathetic inhibition. So if there is no parasympathetic or sympathetic system, you're not going to have atropine work at all. Drugs like adenosine, the heart is very sensitive to. So you need to give half dose. So like that, each drug has got a difference in the way it works. A lot of times you may have a delay in the response to exercise. So the tachycardia does not happen soon after exercise. It will be delayed until you have hormonal secretion and sympathetic response from the hormones, not from the nerves. So there is a whole lot of transplanted heart physiology which is different from normal heart physiology, which you need to understand once you do this. And in the lungs, same thing happens. You do not have any sensation in the bronchus. So if you have sputum sitting in the bronchus, you're not going to know. You don't get the feeling. So you have to coach the patients in order to make them cough even if they don't feel anything. So all organs have got its own difficulties, but it works even in the absence of nerves. Another interesting thing is when people did dog experiments in the past for lung transplants. Dogs cannot have denervated lungs. They don't work because they need to pant very fast, and in the absence of nerves, they cannot do that. So when they did dog experiments on for lung transplants, all the canines died because they just wouldn't breathe, to the point that they thought lung is not a transplantable organ. Then somebody started doing experimental transplants on primates. So as an animal experiment, lung transplants can be done only on primates.
Someone asked if you could talk about the first heart and lung transplant in Karnataka that you performed.
I think we did the first heart and lung transplant about 3 years ago, January 2019. Yeah, some 2019 or 18, I don't remember correctly. I think it is 19. So that'll be 3 years now. So yeah, it is 2019 January. This gentleman came to us with lung disease, and on evaluation, he had severe coronary artery disease also. So we thought we will do a heart and lung transplant. He was 69 years old at that time. Now he's past 70. And I think that's a good age to do lung transplants and heart lung transplants, because the median survival for these are, somewhere between 5 and 10 years. So if you extend the life of a 20-year-old by 5 years, it really doesn't mean a lot compared to extending the life of a 70-year-old for 5 years. So, I do not really take age as a contraindication in these patients. So we did this transplant at that time. He was in the hospital for maybe a little over a month or more than that. But he really took about 9 months to get back to full recovery. So we have a very good pulmonologist who persisted on looking after him. And strangely, he had a rejection of his heart, which is not the norm. If you do a heart lung transplant, it is said that you don't even need to monitor the heart, just monitor the lungs. But this gentleman had a heart alone rejection, which was treated, and then he got better. But today he's quite healthy and he's doing quite well. And somehow COVID did not hit him, and he's been fine so far. That was that was quite a landmark in transplants for us. Sorry, I can't hear you. You're on mute. Arpita, you're on mute.
Sorry. Yeah, sorry, sir. Yeah, someone asked if you can replace an infected area with stem cells.
All that have been tried. This doesn't work.
Okay.
If people have injected stem cells into an infarcted area, but infarcted area does not become muscle.
Someone asked about the IABP mechanism, intra-aortic balloon pump.
So IABP works in a couple of different ways. One is that the balloon occupies 40 cc in the aorta. When at the onset of systole, the balloon deflates. So suddenly there is a 40 cc space that is formed there, which is pretty much close to the stroke volume. So the heart finds it very easy to eject into a place which is empty, as opposed to the systemic vascular resistance, which is faced with blood pressure, etc. normally. And because that is the systolic part. And because of the inflation during diastole, the coronary blood flow is improved tremendously. So primarily, these are the two ways it helps. It doesn't increase the systemic blood flow to an extent that all the other devices do. So IABP is good for the heart, but not so great for the rest of the body. ECMO is great for the rest of the body, not so good for the heart. So, it depends on what you're using it for. If you have coronary artery disease, IABP is a very good tool to use. And there have been some modifications of IABPs which have been developed, which can be used on a long term, and patient can be sent home. It's not the same balloon. It is usually put in through an axillary graft, and then it's got a detachable portion which comes out like the LVAD's line. And these have been tried out as a bridge to transplant with people at home. But normally IABP has got lots of complications in terms of peripheral ischemia, etc. And it's not something which you can use for a long time.
Someone asked if COVID causes any complications in heart transplant recipients.
We've been debating that and studying that. I can't say for a long time, ever since COVID started. So we weren't that sure if immunosuppression is going to make things worse or get things better, because a lot of deaths from COVID is an immunological phenomenon and hyperimmune response and all of that. But anyway, patients who had a transplant are more susceptible to getting COVID. But in terms of outcomes, it depends on the severity of the disease, and it's probably not very different from the rest of the population. Susceptibility is certainly more because of immunosuppression, but outcomes, I'm not very clear. We've had some patients die following COVID after heart transplant. I mean, almost all hospitals have had somebody who got large volume of patients who are around now.
Yeah, I think that's it for the questions. We'll be posting a form on the chat box, and you can get your certificates if you fill out that form. It has a bunch of questions in it.
On the chat box, I don't see anything there. Oh, there are some questions here. Disco. Okay,
Yes.
these are the ones you asked me. Okay.
Yes, sir. I
Fine.
think that's it.
All right. So thank you very much for the opportunity. I hope I didn't bore you too much for such a long time.
Yes, sir. Okay, I'll end the session now with the vote of thanks. It is an honor for me to get the opportunity to thank all the dignitaries on behalf of the IMA MSN unit of RRMCH. I would like to express my gratitude to all the participants of the webinar for their presence and contribution to make this webinar a great success. I extend my gratitude to Dr. Julius Punnen to take out time from his busy schedule to grace the event. Thank you for inspiring and encouraging us with your words on this special day. I extend my gratitude to the organizing team and volunteers for working hard for the past few days to make this webinar successful amidst the pandemic. I congratulate all the delegates for their active participation. Thank you everyone once again for making this a great success. Okay, we'll be posting the form now, I think. I'll forward it on the chat box and y'all can fill it in. Thank you, sir.
All right. Bye.
Bye. Okay, so for the participants still here, there's a World Heart Day Marathon that starts from 30th September and all participants get certificates. So you can register for free. I think we'll forward the link to you on the chat box.